Hello, good afternoon, everyone, and welcome to this viral session on patient safety and infection prevention and control, one of the 10 sessions under the Hospital Operations track of the first National Hospital Week Research Forum. I would like to acknowledge the attendance of the chiefs of hospitals and medical centers and other officials in this session. Good afternoon and welcome to our session. The call for abstracts for this research forum resulted in 212 submissions. These submissions underwent a stringent screening process and selection. In this session, we shall acquaint ourselves with three that have successfully qualified for presentation. Each of the researcher presenters in the session shall have 15 minutes to present their papers. After, we shall have 10 minutes to answer questions from the audience. The audience is on mute in the entire session. You can post your questions on the chat panel of this virtual session room. You can see the button that will open the chat panel at the bottom right of the screen. A maximum of one question per presenter only. Identify the presenter first, then your question next. Before we close the session, we shall have the synthesis and some onward announcements in the forum program. Presenters in this session are the following. First, we have Mr. Halen Tawali from Mariano Marcos Memorial Hospital and Medical Center with Too Gentle to Handle and IV burn among pediatric patients. Second, Ms. Rufa C. Tepaz from National Kidney and Transplant Institute, review of fall incidents at the NKTI, a retrospective study. And last but not the least, Ms. Riza Coros from the NKTI as well, with moral distress among staff nurses working at NKTI confronting end of life issues. To our researchers, thank you for joining this forum and congratulations for reaching this far into this platform. Let us now start with the presentation of Mr. Tawali. Mr. Tawali, the floor is yours.
Good afternoon to everyone. Safety is the priority when dealing with patients confined in the hospital. Pediatric patients are considered to be vulnerable population. What if in the course of hospitalization, a patient develops IV burn? This is the CQI study of Department of Pediatrics and different units handling pediatric patients. Too gentle to handle and IV burn among pediatric patients. Good afternoon to everyone. I am Halen Tawali and I will be the one to present the CQI study. This is the collaborative effort of the Department of Pediatrics and Nursing Service, particularly staff nurses from the different units handling neonate and pediatric clients at the PICU, NICU, and pediatric wards. Intravenous infiltration injuries are inadvertent delivery of non-vesicant fluid or medication into surrounding tissue that has the potential to harm the patient. Extravasation, on the other hand, is the leaking of vesicant fluid into tissue spaces. Severity of resulting injury usually depends on the type and amount of fluid allowed to enter the tissues before the infiltration is detected. The longer it remains undiscovered, the more severe the resulting harm, and this may lead to IV burns and blisters, nerve injuries, and worse, permanent disability. Unfortunately, the pediatric population is at greater risk than adults for infiltration because of many factors. Numerous case reports were published with regard to intravenous injury among pediatric patients in different hospitals around the world. A retrospective study conducted by Paquette et al. In 2008 in Canada revealed 0.04% incidence of intravenous injury per day. A similar study by Wilkins et al. Showed reported incidence among hospital inpatients is 0.1% to 6.5%, and the true incidence is likely higher because of inconsistent documentation and reporting. Locally, there are no published cases and reports as to incidence of intravenous injury or IV burn among hospitals in the country. However, a relative study conducted in Cebu revealed that patients who stayed for 7 to 14 days had an increased likelihood of developing phlebitis and infiltration compared to those who remained for 4 to 6 days. As such, intravenous burn is a major concern and could be the one of the predictors of hospital performance along with infection control, needle stick injury, and fall. From the prioritized problems in the different pediatric units, we have identified IV burn as a major concern. There are a total of 4 cases of IV burn from January 1 to February 29, 2020 at the NICU and PICU, which translates to a rate of 2.72% of the total admitted patients in that same period. All of the 4 cases suffered severe burn resulted to debridement, additional use of antibiotics, and extended hospital stay. Thought of its significance that could improve patient care and promote patient safety, this was the prioritized problem. It got a perfect score of 9/9 basing from the criteria set as to injuriousness, feasibility, and urgency to solve. Our priority problem is cases of IV burn among pediatric patients. 4 incidents of IV burn on patients were recorded from January 1 to 2020 to February 29, 2020 is our final problem statement. This is the Ishikawa diagram, which reflects identified root causes of our problem, such as patient factor, material factors, drug formulation factor, methods, immediate caregiver factor, and manpower, which all lead to IV burn. The root causes were validated and verified its controllability. This is the Pareto diagram, which reflects the frequency of causes identified. 80% of the cases identified contributed from the 20% of the causes. Among them, the top 4 frequently identified causes are pediatric population are uncontrollable at times, poor quality of IV catheter, infusion pump have no safety features alarm even in the presence of infiltration, appropriate use of inappropriate syringe size during medication, and the least identified causes are use of non-transparent plaster in securing IV line, failure to observe SASH, inappropriate selection of IV site like areas of flexion, and nurse attend and intervene first on more critical condition of other patients. Identified root causes that are true cause and within our control were considered. So the final problem statement is to prevent incidents with 0% recurrence of IV burn in all areas in the third quarter of 2020 and beyond. On identification of the true causes of the problem, we came up with alternative solutions, controllability, advantages and disadvantages of the proposed solution, and decision. If the total criteria is more than 10, it is considered a go, and if the score is less than 10, it is a no-go. On the true cause on neonates, infants, and children are uncontrollable at times, the best alternative solution is to educate immediate caregiver upon admission. The solution is controllable with a score of 13 and the decision was go. Another solution for identified previous true cause is securing a consent from form regarding shared responsibility of care between health providers and significant others. The solution is controllable and got a score of 12 and the decision was go. On infusion of concentrated and vesicant drugs, the solution is that all antibiotics should be diluted and will be infused via volumetric infusion set. It is controllable and got a score 15 and the decision was go. On failure to observe SASH, same solution with infusion of concentrated drugs. It is controllable and got a score 15 and the decision was go. Inappropriate selection of IV site like areas of flexion can be resolved with surgery for IG or IV cut down as the last result. The solution is controllable and got a score of 11 and still the decision was go. Nurse attend and intervene first on more critical condition of other patients. There should be proper orientation among the immediate caregivers upon admission. The solution is controllable and got a score of 13 and the decision was go. Use of inappropriate IV catheter size to cannulate the vein. The alternative solution is to conduct regular course orientation and reorientation of staff on IV therapy. Solution is controllable and got a score of 10 and the decision was go. Use of inappropriate syringe size during medication administration is to use volumetric infusion drip and not direct IV using syringes. The solution is controllable and got a score of 15 and the decision was go. The prioritized solution got a score of 15/16 based from the set criteria as to effectiveness of the solution, probability of success, ease of implementation, and the reasonable cost. Analysis on the potential problem of the best alternative solution was done wherein preventive action and contingency plan were implemented. During the implementation of the best alternative solution from July to October, A significant result of 0% recurrence of IV burn was yielded. Therefore, the solution implemented was successful. Projected additional expenses from patients who incurred IV burn will range but not limited to additional room rate, additional medical supplies, cost of procedure, and additional use of antibiotics and other medicine compared to using only 2 sets of volumetric infusion for an antibiotics and for other caustic drugs. The projected savings of each patient will be 18,516 pesos. Intangible benefits may impact the organization as to attainment of an injury-free reputation of the hospital, lessen and prevention of avoidable expenses to the patient, prevention of additional emotional and psychological burden on immediate caregiver, enhancement of sense of accountability and responsibility of the pediatric nurses. Future plans will include meeting with the adult healthcare unit personnel to adapt the study output and strict implementation of the policies and guidelines on IV insertion and medication to maintain 0% recurrence of IV burn. From this, we successfully ended IV burn among pediatric patients. Thank you and good afternoon.
Thank you, Mr. Tawali, for your presentation. Okay, so now let's move on to our second presenter, Ms. Rufa C. De Paz from the National Kidney and Transplant Institute with review of fall incidents at the NKTI and retrospective study. Ms. Rufa, the floor is yours.
A pleasant afternoon to all our panelists and our participants for this session. I'll be presenting the study entitled Review of Fall Incidents at the National Kidney and Transplant Institute, a retrospective study. I am Rufa De Paz, a quality assurance and research nurse at NKTI, and my co-authors are Dr. Nerissa M. Jurial and Ms. Katrina Bianca Palanca. As a background for this study, let us first define what a fall incident is. So a fall is defined as an event which results in a person coming to rest inadvertently on the ground or floor or other lower level. Falls are a major public health problem and the second leading cause of accidental or unintentional injury and deaths worldwide. That is according to the World Health Organization. And fall prevention has been the subject of intensive research and quality improvement efforts. Inpatient fall has been a major safety concern for patients, such that it can increase the length of hospital stay and can psychologically and financially affect both the patient and the hospital. The effects and injuries, Hello, sorry. Hello?
We can hear you, ma'am.
Okay. Sorry, was I clear from the beginning?
Clear, ma'am, from the beginning.
Okay, I'm sorry. Okay, so as I was saying, initiatives to define and further explore risk factors should be initiated to effectively utilize fall prevention strategies. So fall prediction involves the design of signal processing techniques and algorithms for reliable estimation of fall risk and providing timely alerts before the occurrence of a fall. Fall prevention is focused on the design and implementation of techniques and intervention programs for mitigating fall risk factors, improving gait and mobility, and preventing a future fall. So both fall prediction and prevention are complex multifactorial problems due to the interaction between psychological, behavioral, and environmental factors that contribute to a fall. Fall risk assessment is also important because it identifies intrinsic and extrinsic risk factors that help determine the most appropriate intervention for effective fall prevention. This conceptual framework shows the various fall risk factors and complex interactions between them. For the objectives of this study, in line with the patient safety advocacy of the hospital, the researchers conducted a retrospective study which aimed to determine the fall rates, fall-related injuries, the characteristics and risk factors contributing to falls and fall-related injuries at the National Kidney and Transplant Institute in a 5-year period from 2015 to 2019. Another is to review the safety measures implemented and revise a fall risk assessment tool to identify the patient who is likely to fall and fall intervention strategies to prevent the patient from falling or to protect the patient from injury should a fall occur. For the methodology, this is a quantitative cross-sectional descriptive study conducted at the National Kidney and Transplant Institute, Quezon City from January 15 to December 2019. These studies limited to patients admitted at NKTI from the General Nursing Department and Critical and Special Care Department, excluding patients seeking consult at the outpatient doctor's clinic. No sample size estimation and no method of sampling was utilized. Data collection was retrieved from the inpatient fall incident report submitted to the Nursing Services Office upon the approval of the Deputy Executive Director for Nursing Services. The fall rates, fall-related injuries, and the characteristics and risk factors contributing to falls and fall-related injuries were studied on the basis of 11 variables, namely age, sex, diagnosis, distribution of patients by shift, distribution of patients by unit, the assistance received, the distribution of patients by fall risk assessment, and the circumstances surrounding a fall, outcomes or severity of fall-related injuries, and the risk factors present. So for the results and discussion, over the five-year period, an increase in the number of fall incidents has been noted. Although this may seem as a negative trend, it also signifies the strengthening of the culture of reporting and continuous monitoring of patient-related incidents in the Institute, such as by the use of the Nursing Services Efficient, Effective, and Equitable Nursing Program, wherein healthcare performance indicators are also measured, providing basis for implementation of new policies that are patient-centered and directed towards patient safety. The highest age group with fall incidents is from those aged 60 years old and above. From year 2015 to 2019, more than 40% of fall occurrences each year are identified to be in this age group. Below 20 years old age group has the lowest incidences from 2016 to 2018. As for the variable of sex, results showed that starting year 2017 to 2019, higher percentage of fall occurred to female. This supports the findings of Cruz and Stevens that women fall more frequently than men, and that the odds of falls in women resulting in bone fractures were 2.2 times greater than those of men. However, the findings reported by Chai and Hendrich found that the odds of men falling were 1.69 times greater than those of women. There are inconsistent results with regards to this variable, and further studies in the future would visibly assess its significance in inpatient fall. Among the diagnoses, chronic kidney disease has the highest percentage recorded for patients with fall incidents, with 50.88%, following our malignancy, acute kidney injuries, and GI disorders with 14.79%, 7.10%, and 5.92% respectively. In a study by Papa Constantinopoulou, it was stated that the chronic kidney disease and end-stage renal disease patients have a higher risk of falls and fall-related fractures, also hospitalization and mortality. Patients suffering from CKD are more prone to fall and develop fractures than the general population. Multiple risk factors have been identified and analyzed to explain these facts, such as drug combination, diabetes mellitus, orthostatic hypotension, vitamin D deficiency, sarcopenia, and anemia are all very common in CKD. In this study, greater number of falls occurred during the morning shift from 6 a.m. to 6 p.m. compared to that of the night shift, 6 p.m. to 6 a.m. It is consistent with the findings of Normie and Abreu. However, several studies depict that fall are likely to happen during the night shift. So in the morning, patients are busy with self-care activities and may not call the nurse for assistance. It is also noted that during daytime, patients are often left alone by companions to perform other tasks and errands. On the other hand, at night, patients usually do not ask for assistance from the nursing team. And records showed that patients hesitated in asking the assistance of their caregiver because they were sleeping. So findings in this study showed that most of the inpatient fall happened in the clinical areas compared to the critical areas, specifically on the second floor wards. This could be attributed to patient-nurse ratio in the wards and because patients in the critical areas are usually on close monitoring and are frequently being assisted for self-care and activities of daily living. Also, unassisted falls account for 87.58% of recorded incidents for the 5-year period. According to STAGS, the rationale using the assisted and unassisted classification in quality measurement is that a high proportion of assisted falls suggests processes in which healthcare personnel can recognize the high-risk patient and institute supervisory processes during mobilization. By contrast, a high proportion of unassisted falls suggests ineffective processes of care, as patients at risk for falling are ambulating and falling without staff assistance. Upon review of patient-related incident reports, most incidents happened with a companion in the room, noting that most of them were asleep and patients did not ask for assistance. Unassisted falls are more likely than assisted falls to result in injury and should be considered as a target for future prevention. Now, this table shows the distribution of circumstances surrounding a fall. Getting up from the bed was the most common circumstance of patient fall, along with walking towards the bathroom and during toileting and bathing. Balance deficit was among the highest risk factor recorded among the total incidents, next to body weakness, disorientation, mobility limitation, and syncope. The results of this study may be explained by overestimation of one's functional capacity, presence of risk factors mostly caused by the experienced disease process. Also, there's lack of caregiver supervision or averseness to call for help, and possible decreased number of nursing staff on duty. Removal or minimizing of environmental hazards must also be observed, along with always raising the side rails, as most of the incidents occurred with side rails down. Findings shows that patients and relatives would occasionally put side rails down despite safety reminders from the nurses. 44.38% of the incidents of fall over the 5-year course obtained minor injuries. Patients noted to suffer severe injury generally needed surgery-related treatments and rehabilitation, mostly due to fracture and other severe head injury. Relative to adults and other age groups, elderly patients following a fall have a unique bodily injury pattern, worse outcomes, and higher mortality. So one major difference in the geriatric population is skeletal fragility, which occurs as the bones become more susceptible to the mechanical forces of trauma. Consequently, the elderly patients will sustain more severe injuries with lower force mechanisms than their younger counterparts who have greater bone densities. So for the conclusion, falls in the institute mostly affect older patients aged 60 years old and above. Balance deficit was among the highest risk factor recorded next to body weakness, disorientation, mobility limitation, and syncope. Majority were diagnosed with CKD and malignancy, are often unassisted, and involves ambulation and elimination-related activities. Extensive effort and studies should be employed to prevent falls from happening and reduce fall injury rates, including review of existing fall prevention strategies, as well as potentially effective interventions. For our recommendations, first is to review and revise the current fall risk assessment tool used by the nurses in the institute. We are currently in the process of revising our nursing assessment and admission form, which includes the fall risk assessment tool that will be used to evaluate patient fall risk. Second is to implement programs and innovations to support the overall patient safety advocacy with emphasis on complete and timely reporting of fall incidents, staff education, and placement of posters and flyers on fall prevention in strategic locations. Lastly, there should also be a follow-up and further study to reassess the improvement of methods to prevent falls, which will also include the outpatient services. So just to share, we currently have the Prevent Fall Care for Patient as one of our strategy in fall prevention in the Institute, where C stands for Create a Safe Environment, A stands for Assess Patient's Risk, R, Reduce Patient's Risk, and lastly E, to evaluate the intervention. Thank you very much.
Thank you, Ms. Rufa Sidipaz from the NKTI for sharing us your study. I would like to remind the audience that you may submit your questions to the presenters through our chat panel at the bottom right part of the screen. Okay, so we are now down to our last presenter for this session. I would like to call on Ms. Riza Coros from the NKTI for moral distress among staff nurses working at NKTI confronting end-of-life issues. Ms. Coros, the floor is yours.
A pleasant day to our panel of judges. I am Riza Karas from the Intensive Care Unit of the National Kidney and Transplant Institute, and I will be presenting our study entitled Moral Distress Among Staff Nurses Working at National Kidney and Transplant Institute, Confronting with End-of-Life Issues. The general objective of the study is to determine the level of moral distress. Moral distress, as defined by the American Association of Critical Care Nurses, is what occurs when you act in a manner contrary to your personal and professional values, which undermines your integrity and authenticity. It is the emotional state that arises from a situation when a nurse feels that the ethically correct action to take is different from what he or she is tasked with doing. Nurses frequently make ethical decisions in the course of their work, but in practice, they cannot always act in accordance with their beliefs. Their conflicting loyalties and responsibilities to patients, families, physicians, and other nurses, as well as constraints, increase the moral distress experienced by the ICU nurses. Many studies abroad have been done regarding incidents of moral distress among nurses in critical care. However, no similar study is known to be published in the Philippines. Conducting this study will give better understanding as to what may contribute to the level of moral distress among staff nurses. The general objective of the study is to determine the level of moral distress among staff nurses working at the National Kidney and Transplant Institute who handled patients with end-of-life issues from the months of September to October 2019. In addition, it sought to answer the specific objectives in determining the demographic profile of the participants. These are the variables that can contribute to the moral distress of staff nurses in terms of age group, gender, number of years working in the institute, and their unit assignment. This is a quantitative, cross-sectional, descriptive study conducted at the National Kidney and Transplant Institute in Quezon City, Philippines, from September to October 2019. The respondents consisted of rank and file nurses in both clinical and critical care areas who experience handling end-of-life issues and are working at the National Kidney and Transplant Institute. The overall population consisted of 289 staff nurses. Among the staff nurses in NKTI, 169 respondents were from critical care areas, whereas 120 staff nurses were from clinical areas, utilizing 5% as the margin of error in Sleuven's formula. The sample size estimated was 166 staff nurses. The study utilized a stratified random sampling technique. A revised moral distress tool by Anne Bale Hamrick which has a unique scoring scheme designed to give a measure of the current level of moral distress, was given to the participants once they have read the participant information sheet and have signed the informed consent. Based on the analysis and interpretation of the data gathered, findings revealed that the respondents' profile in terms of age, 40.96% of the respondents are from ages 25 to 28 years old. In terms of gender, 68.67% are female. In terms of number of years working in the institute, 36.14% of the respondents were from working for 1 to 2 years. Lastly, in terms of areas or unit, 13.86% of the respondents were assigned at the emergency room. The researchers determined that the overall assessment of the respondents in terms of frequency and level of moral distress on variables affecting moral distress are 1.41 sometimes and 2.11 medium, respectively. Lastly, the researchers found out that age, gender, and years of working in the institution do not affect the level of moral distress because based on the test, different levels of age, gender, and years of working resulted to the same response. Whereas the assignment of area or unit affected the level of moral distress, which proposed a significance. Based on the result, there are areas or units that cause high or low moral distress. In conclusion, among the demographic characteristics of the respondents in terms of the profile, majority of them are from ages 25 to 28 years old, female in gender, 1 to 2 years working experience in the institute, and assigned at emergency room. Most of the respondents assess the variable follow the family's wishes to continue life support, even though I believe it is not in the best interest of the patient, as ranked one factor on the level of moral distress among staff nurses working at National Kidney and Transplant Institute, confronting with end-of-life issues in terms of frequency. While initiate extensive life-saving actions when I think it only prolongs death, is the rank one factor of level of moral distress as assessed by respondents. Finally, based on the testing of the significant difference between factors when grouped according to profile, the researchers found out that the most affecting profile is the area or unit of assignment of respondents. Based on the analysis and interpretation of the data gathered, findings revealed that the respondents' profile in terms of age, 40.96% of the respondents ages from 25 to 28 years old. In terms of gender, 68.67% are female. In terms of number of years working in the institution, 36.14% of the respondents works for 1 to 2 years. Lastly, in terms of areas or unit, 13.86% of the respondents were assigned at the emergency room. The researchers determined that the overall assessment of the respondents in terms of frequency and level of moral distress on the variables affecting the moral distress is 1.41 sometimes and 2.11 medium, respectively. As what was discussed and found out based on the testing of significant difference between factors when grouped according to profile, the researchers conclude that the most affecting profile is the area or unit assignment of respondents. For our recommendations, we can create an environment where nurses can speak up about their needs, offer counseling services to nursing staff, especially in times of distress. Reach out to professional associations for activities to improve their knowledge skills. Apply clinical rotation of nurses to enhance their experience at the bedside. Have them attend stress management seminars and encourage them to participate in these. If we could give the nurses this and do more studies on moral distress and how it affects the overall being of the nurse, we would be able to improve the outcomes and create a healthy community where nurses and allied health professionals can avoid moral distress, and be able to thrive. Thank you.
Thank you, Ms. Riza Chorus, for sharing your presentation with us. I would like to remind all the audience that you may now post your questions in the chat panel on the bottom right of the screen. Our presenters are very much willing to answer your questions. All right. So again, thank you all for those presentations. Um, all right, let's wait for a few moments for the questions. No questions? Okay, sige po. We'll be proceeding po with our synthesis. But if you do have questions, just send it to us and then we will be... Oh, here, there's a question po. Ms. Joy, could you please share with us the question?
Hello, Doc. Well, the question is, how did the researchers respond to the participants who reported high level of moral distress during the survey?
I think this question is directed to Ms. Riza Coros from the NKTI. Ms. Riza Coros, just to repeat po yung question, how did the researchers respond to participants who reported high level of moral distress during the survey?
Ay, hello po. Can you repeat the questions?
How did the researchers respond to participants who reported high level of moral distress during the survey? So Mr. Paul is asking, what were your interventions during the survey when they told you that they were distressed, like on the onset po?
Um, after after we received after the we received the that the emergency room has the highest level of moral distress, program for stress debriefing were conducted at the nursing service office.
All right. Thank you po, Ms. Corres, for answering the question. Another comment po from Mr. Joel Vileno. Maybe the nursing division should mandate all the nurses for regular stress debriefing. So I think that's what Ms. Corres mentioned po no, na what they did was to have the regular stress debriefing sessions po. All right. Okay. Thank you po. Are there other questions? Okay, I think none na po for our presenters. Okay, sige po. So, for synthesis na po tayo. Okay. Sige po. Yung questions po will be included in the documentation of the activity po. Alright. Okay. So, as synthesis po for the first study from Mariano Marcos Memorial Hospital, to prioritize solutions done where the concentrated drugs and all antibiotics should be diluted as prescribed or as specified by manufacturer and will be infused via volumetric infusion set. And the other prioritized solution was all medications will be placed on a volumetric infusion drip and not direct IV using syringes. The implementation of these resulted to 0% recurrence, as shared by Mr. Tawali for July to October, with projected savings of 18,516 per patient. As for the second study, in the review of fall incidents at the NKTI, a retrospective study, the falls were mainly affected those above 60 years old, with the balance deficit as the highest risk factor, and the majority were diagnosed with malignancies and CKD. As recommendations, they are to revise the fall assessment form and to have reorientation of staff and strict implementation, placing of posters in strategic locations, conduct further studies on fall prevention involving the outpatient services. And lastly, for the third study, moral distress among staff nurses working at the NKTI, confronting with end-of-life issues. They use a stratified random sampling technique with a revised moral distress tool with a study population of 289 staff nurses. It was found out that the most affecting profile is the area or unit of assignment of the respondents. So, through these studies that were shared to us by the presenters, we saw the importance of prioritizing the vulnerable populations, so the pediatric and the elderly, and that care for them must be given appropriately. We also saw the importance of having appropriate tools for measurement, and this was reinforced as we saw that these tools could be used for performance management and for improving health outcomes, not only of the patients, but also of our healthcare workers. So, and that's all the time we have for this parallel session on patient safety and infection prevention and control of the hospital operations track of the first National Hospital Week Research Forum. Make sure you're all able to log into your next parallel session in time. As some of you are aware, there are 30 papers out of 60 presented in this forum that are in the running for Best Research Paper. The winners will be announced and awarded at the closing plenary session of this forum. We also expect all of you to join then. Before the first National Hospital Week Research Forum formally closes, the link to the post-activity evaluation form will be announced and posted. All those who will be able to fill up the online post-activity evaluation form will receive a certificate of attendance in return. The spiral session has concluded. Thank you for your participation. You may now click on the leave button or the round X button on the bottom right of the screen. See you all at the closing and awarding ceremony. Maraming salamat po.